We also have our other panelists who will join us in a little while. I'm going to make the names, announce these names. The chairman and founder, Narayana Health, Dr. Devi Shetty is going to be with us. Commissioner, Health and Family Welfare Department for Government of Karnataka, Shri. Dr. Soumya Swaminathan, Chief Scientist, WHO. She will be joining us virtually for this talk and session. And the session will be moderated by the founder of ThePrint, Shri Shekhar Gupta, in just a couple of minutes. I'd request all the guests to please take your seats. We are about to start the session. I'd like to remind our audience that the session presently is on transformation of healthcare. That's the segment we are looking at. I'd like to invite now the Honorable Minister for Health and Family Welfare and Medical Education for the Government of Karnataka, Dr. Sudhakar, onto the stage. Sachivarige swagatavanna korona. I request everyone to energize this auditorium with a round of applause. There have been very thought-provoking sessions in the beginning. We also have the chairman and founder, Narayana Health, Dr. Devi Shetty, with us joining the panel. Namaskara, Swagata, Dr. Sudhakar. Also the Health and Family Welfare. We are going to be having one chief panelist joining us virtually, Dr. Soumya Swaminathan, Chief Scientist, World Health Organization. And the session will be moderated by the founder of ThePrint, Shri Shekhar Gupta. It's over to you, Shekhar.
Welcome to this session. In West Karnataka, healthcare, in conventional wisdom goes that healthcare and investments, business, entrepreneurship, etc. don't go all together. But they always did, and they always will, and they do. And what the pandemic has taught us is that it's not a question of whether you need capacities, healthcare capacities, in the public sector, government sector, or the private sector. It tells you that when a real crisis comes, then you need facilities everywhere on mass scale in any case. But even in normal times, all universes have to intersect. They have to complement each other. And there will be various choices for various categories, economic categories, social categories, and various disease categories. The other thing that the pandemic has done is that I know that many of you in this audience, and Dr. Shetty for sure, have experience of medical education. The minister handles and leads medical education in a state known for its educational facilities. That public health in particular has always been seen to be not the top priority for medical graduates. That is, if you don't get in anywhere else, because you make money maybe in cardiac surgery, maybe neurosurgery, maybe in so many areas, but not really in public health. But again, this pandemic reminded us that this is public health, mental health, two most important areas of medicine. So there was a world that we lived in before the pandemic. There is a world that we are living in now, and that is the world after the pandemic. So to discuss how we go ahead and how we implement these lessons learned during the pandemic, we have these three marvelous panelists who I will not now waste time introducing. You know them all very well, also because we are running a little bit behind schedule. So without much ado, if I may ask Dr. Swaminathan to make maybe a few opening remarks, and once that is done, then we'll have the others, and then we'll follow this pattern: opening remarks by her, by the minister, by Dr. Devi Shetty, just go left to right, and then we'll open it up for discussion amongst themselves. And then, do we have time to take questions from the audience? Yeah, okay, all right. So, Dr. Swaminathan, please, and we apologize to you that we are a little bit late. Usually, I'm the usual suspect, so I am the default guilty party. Even if I'm not the guilty party, I'm happy to take the blame.
Ma'am, sit back. Sit back a bit. Great, ma'am. Thank you.
changes this.
Shekhar, are you able to hear me?
Yes, I am able to hear you. Hi. Just to see you, we have to turn around, but I can hear you. Yes.
Okay, I had just a couple of minutes loss of connection, so I missed what you said at the beginning. I was connected in.
I will tell you what I said. Besides the usual introduction that where you didn't miss very much, I said that we are starting this session late. Now, I'll not go into who's to blame because I'm the usual suspect. So even if I'm not to blame today, by default, I will take the blame. So I apologize and let's go ahead from here.
Thank you. Thank you very much.
So please go ahead. I said that we'll start with opening remarks from you, and then the two other panelists, and then I'll ask you all questions, and then we'll take it to the audience. So why don't you start with some opening remarks?
Okay. So thank you very much, Shekhar, and it's indeed a pleasure to be on this panel with the Minister Sudhakar and with Dr. Devi Shetty on a really important topic where I think the overall theme of the conference is about investment. And I think that's the word that I would like for us to think about in terms of health. So anything that we put into health, I think we should think of as an investment and not as an expenditure. So that's really the first message, because we've seen that without health, everything else really doesn't exist and doesn't happen. And the whole world was in chaos thanks to a tiny virus which caused this pandemic. And it also exposed a number of problems, as well as, I think, brought a lot of opportunities for us to harness. So a couple of lessons that I took away from the pandemic is that the first thing is that science and technology today has advanced so much and is continuing to advance at such a rapid pace that it will provide for us a lot of solutions, whether it's going to be in the form of new vaccines, whether it's going to be digital tools, or whether it's going to be new vector control methods whereby we can control mosquitoes. These are all possibilities, and with the advances in genomics and proteomics and gene editing, I think that it is going to be really hard for us to keep up, really. And we have lots of opportunities. But again, that means investing in research, investing in science, investing in building a workforce that's scientifically literate and technologically competent. And Karnataka, I think, is in a very good position, and so are many other states in India. I think the second lesson that I took from the pandemic is that it exposed the inequities and the vulnerabilities in our system. There was no healthcare system in the world, or very few, I would say, that were able to cope up with this kind of a health shock. And that speaks to resilience. And that means that we must always think about having extra spare capacity, particularly in terms of the workforce and particularly in terms of essential commodities like oxygen. And I think this was a lesson learned by many countries. And even though something as basic as oxygen that saves lives from pneumonia and wasn't just essential for COVID, it was COVID exposed that the gaps in oxygen access actually resulted in a preventable loss of lives. And so for investing in the access to supplies, vaccines, medicines, essential commodities, and not to forget diagnostics at the primary healthcare level as well as at other levels is going to be very important. And third lesson is that the underlying health status of the population, as well as the inequities within societies, between countries and within countries, accounted for most of the excess mortality that we saw. So, for instance, even in countries that have a relatively young population, people with underlying illnesses, chronic diseases like diabetes or hypertension or obesity were the ones who suffered. And normally one would think, one is an infectious disease, the other is a non-communicable or a chronic disease, but you can see the links between the two, and therefore focusing on prevention and health promotion as part of our primary healthcare services will not only deliver dividends in terms of improved health, but also reduce the costs that will be incurred in tertiary care. And finally, I just want to give a statistic that we need to think about. While our life expectancy has increased tremendously from the time of independence, I think today our life expectancy is an average of 71 years, the global average of 73 years. We've done very well. But in terms of healthy life expectancy, India's average is about 60 years, which means the last 10 to 12 years of our lives are spent with ill health. And this is again pointing to the fact that we need not only to invest in curative aspects, but in prevention and health promotion. I'll stop there for now, Shekhar.
Well, thank you very much. I'll go to the minister now. We all talk about lessons learned during the pandemic, what the pandemic taught us and how we learned on the move. But what lessons remain? Usually in the governments, everywhere, but particularly in governments, the belief is that once the crisis is over, it's business as usual. So what lessons endure, which we now carry forward, which you carry forward, and which you are now putting into effect?
Thank you, Shekhar ji. First of all, when I assumed the ministership, that was the first time I became a minister. Within a month, we had to face what is called as world's largest pandemic. The COVID has taught us many lessons actually. We are the generation where we witnessed the pre-COVID times, COVID times, and post-COVID times. But during COVID, what we had to learn and what we really try to do our best is, whatever the action, whatever the reaction that was supposed to taken by the government, that was the speed and the size. In the speed in which we had to act, because of our population, we had to increase our infrastructure multifold, augment our infrastructure, and also getting the health staff is not very easy. To augment the health staff is not easy. You can get the equipments, you can build the facilities. We did it, but apart from that, we increased close to about 15,000 healthcare professionals in Karnataka, in addition to the people who are already in the systems of healthcare and medical education. Secondly, COVID also taught us how important use of technology is, especially the artificial intelligence, telemedicine, tele-ICU. These were the first that we started here, because we want to ensure that the healthcare or the health treatment, the tertiary treatment while taking the COVID, should, even a Bidar, a person who is getting treated in Bidar should get the same kind of treatment that the patient was getting in Manipal Hospital or our Narayana, state-of-the-art hospitals in Bangalore. That is why we set up a centrally monitored tele-ICU with 3 shifts, roping in all the best intensivists from the private sector and the government sector. We used to monitor this to minimize the deaths. Post-COVID, as you know, we have started increasing our medical colleges. 5 districts is getting new medical colleges now. By 2023, we are inaugurating all these 5 medical colleges. And apart from that, we are augmenting in terms of facilities. We are building a lot of trauma centers. Intensive care has been initiated. More than anything, the lessons that we should have learned from COVID and we should learn probably is, the future of healthcare should be like this. It should be personalized, it should be preventive, it should be predictive and preventive. We are not speaking about the P, which is the pill. That is the new way of dealing with the healthcare, especially when you're dealing with the public healthcare system.
Are you looking at expanding capacities in some specific areas?
Absolutely. The challenge or the healthcare deficiencies, as we all know that, uh, there used to be a disparity between A and B cities, rural areas and urban components. Even today, though we have met the required doctors population ratio as WHO's recommendation, in fact, Karnataka has bettered it. We have one doctor for every 800 odd people in Karnataka. But when
These are real doctors.
these are real doctors, because I am including even Ayush doctors as well, along with the allopathic doctors. If you are considering only allopathic doctors, then we have one doctor for every 950 population. So the disparity is that even today, even after having so many doctors, whether we have a doctor in the remote areas, no. This is the disparity. Whether a remote area, a person, a villager is getting access to the global standards of healthcare, no. These are the challenges that we have to really face. And that is why our Honorable Chief Minister Bommai for the first time during his budget this year, he has called what is termed as aspirational districts. So we are investing more in aspirational districts and aspirational taluks, where there is not enough healthcare facilities, right from primary to tertiary. We are trying to augment the systems there in the very required, demanding areas.
Dr. Shetty, besides your thoughts, let me also pose two more questions that come from what our two earlier speakers have said. One, this was a virus that told us that there were some things that hit you which didn't care what your economic status was. So whether you were rich or poor, whether you went to the most expensive hospital or just found a neighborhood doctor with 2 beds and oxygen and steroid, you got pretty much the same health care. So what lessons do you take forward from this going ahead? Because you are somebody who's worked in both areas, who's worked in the pure corporate area as well as the pure sort of philanthropic mass area, not exactly philanthropic, but mass area, affordable, very affordable. So what does the pandemic teach us that changes or that modifies our plans and thinking going ahead? And second, after what the minister said, it's one thing to have a doctor per 800 people, but how good are these doctors? What all can these doctors do? How much can a doctor do without some facilities and some care like nursing, path labs, things like that?
Thank you, Shekhar. Thanks a lot. Thank you.
I think we can take this one.
Thanks, Shekhar. Thank you so much. I would, first of all, I would like to thank our Honorable Health Minister for the way he has led the state by getting both private and the public sector together to fight this most difficult period of our life. It wasn't easy, and he has, with his dynamic leadership, he has played a role.
Are we audible to all of you? Yeah, carry on, sir.
Yeah. The second thing about we discuss, when you are speaking, it wasn't audible. I guess why you're indirectly asking me why the Indian mortality of COVID was less compared to the what was projected by various international agencies. Am I right, Shekhar? Is that the question you asked me?
But I'm not able to hear you.
Yeah, there is a problem.
Yes, yes.
Yeah. So essentially how India has done well in...
So I will explain to you, Dr. Shetty and I were having a little conversation here about COVID deaths. And he has a view on why India's average COVID deaths might have been lower than in Western countries. So he's explaining why.
See, the lot of international reports mention exaggerating the COVID death in India, saying that Indian government has undermined the numbers. But my impression, along with all the senior doctors, is that India has done extremely well in controlling the number of deaths, mainly because of the nature of the disease. COVID disease as such, whether in England or in Europe or in India, required only two types of treatment. That is, when diagnosis, you don't need fancy labs, because during the COVID crisis, if somebody has high fever with difficulty in breathing, it is understood without chest X-ray also it is COVID. Now, what is the treatment in England? The treatment in England is oxygen and steroids. And that's all made all the difference in all these expensive injections you gave. We don't know whether it really made an impact. Now, this is available in each and every nook and corner of our country. You drive on any highway, every few kilometers, you find a hospital where they have oxygen, where they have steroids. So most of the COVID patients didn't treat in our hospitals in Bangalore. They were treated in 30-bed, 10-bed, 5-bed nursing homes. That is the reason why we brought down the mortality. And in Western country, they didn't have the privilege because of the zoning system where number of beds are restricted. Whereas a 30-bed nursing home can easily add another 20 beds by borrowing some beds from the neighbor, and he could give oxygen and the steroid. This is what it is. Now, Shekhar, I do not wish to talk about the past. Now, there is an impending crisis waiting to hit this country. That is the shortage of nurses. All over the world, there is shortage of nurses before COVID. After COVID, nearly 10 to 20% of the active nurses in US and Europe, all the developed countries, retired. They don't want to be nurses anymore because the stress of job is so much. They decided not to be nurses. Now, these countries cannot go on because in US, nurses' salary has gone up 3-4 times. It is unsustainable. So first thing they will do is to look at country like India, and all we need is 10% of our active nurses to leave our hospital. And all these nurses will emigrate, are not the nurses working in the government hospital. Government hospital nurses will never leave. It is a private sector hospital where 60 to 70% of the patients are treated. And that will have a massive impact because as a senior doctor, I can tell you, in a hospital who takes care of the patient is not doctors, it is the nurses. Now, do we have an option? We have a phenomenal option which we can implement right away. Since the Honorable Health Minister is here, let me tell you how we can address. All we have to do is to ask all the hospitals with over 100 beds to start a nursing college with the intake of 50 or 100 students based on the number of beds. A 500-bed hospital may take 100 nurses. And the entire training program of nurses should change from the classroom training to the bedside training. Today, nursing training is exactly like you want to train somebody to swim, you have to put him in the swimming pool. You cannot train people to swim in a library or in a classroom. And that has to change. The second thing, I'll give you one simple comparison, Shekhar. At the age of 18, some boys and girls want to become nurses, they join nursing college. At the age of 18, some boys and girls want to become pilots. They join pilot training institution. At the end of 10 months, a pilot training program recruited boy or a girl will get the license to fly a plane with passengers in it. But a nurse who spent 4 years in the nursing college, when she graduates, she is just a beginner learning how to be a nurse. There is something dramatically wrong with the way we train nurses. Nurses from first year onwards should be taught how to interpret a ECG, how to look at the cardiac monitor and find out why the patient is in low cardiac output. They should be able to interpret all the blood gas report, because a pilot sitting in the cockpit looks at only the indicator coming in front of him. Nurses standing in front of ICU patient, all the data points come. They should know why that is happening and inform the doctor. And that can be done within 1 to 2 months of hands-on training. So we need to tell ourselves that the nursing training program is to train nurses to manage a patient on a ventilator in ICU. And if you train the nurses with that intention, they can be very good community nurses, or they can work in any other hospital. We have to change our attitude.
Well, that's a very good point, and I think that carries the argument forward. So, Dr. Swaminathan, or Soumya, if I may, do you agree that nursing is a coming crisis, the shortage of nurses? And what is a crisis is also an opportunity, because India is also a country that needs to generate jobs. And India should have depth in its educational system, particularly medical education system, to focus on nursing, which hasn't been done adequately. And we have the minister himself sitting there. So then I will turn over to him. So please go ahead.
Yes, I do agree with what Dr. Shetty was saying in terms of in the Western countries, certainly there has been this, what they call the great resignation, where both nurses and doctors are leaving the profession because they've been completely burnt out in the last couple of years. And they will be looking at, despite all the international treaties and talks there are about not, taking resources away from developing world, these countries will attract healthcare providers, from countries like India, or well-trained nurses from other parts of the developing world to themselves. So there is a chance that would happen. But I think it also opens up the broader question of, do we have enough of the other types of healthcare providers other than doctors? I think in the last couple of years, there's been a huge amount of investment in opening new medical colleges and training more doctors. Now, there is no guarantee that these doctors are going to go and serve in those districts. As the minister was saying, that they will always continue to be districts where doctors do not want to go, and nothing will be able to persuade them to go, and we must think about incentives for them. But there are many things that can be done at the primary care level where you don't necessarily need doctors. And the kind of training that Dr. Shetty is describing perhaps is an individual you might call a nurse practitioner. I mean, these kind of ideas have been around in the past about training people who can deliver primary health services, particularly when you have a standardized algorithm to help them. If they come across a pregnant woman, what are the steps they have to do? And using telehealth now, it is very possible for this type of a person, whether they are called a nurse or a nurse practitioner, in the old days they were called an RMP, somebody who has 4 years of basic training, practical hands-on training, and then is mentored, not just left to their own devices, but continues to be mentored by doctors and specialists who may be sitting in the district hospital or in a specialty hospital, but through telehealth will be able to guide them. And this, I think, is something that we need to really invest in, because the other categories of people are lab technicians, physiotherapists, because we're talking about universal health coverage, which goes all the way from health promotion and disease prevention to diagnosis and treatment, but then also to rehabilitation and palliation. And as our population is getting older, life expectancy is increasing, which is a good thing. We have to understand that chronic disease burden is going to increase. And therefore, we also need to think about how we're going to look after people with morbidities. They are going to need spectacles, they're going to need cataract, they're going to need hearing aids, they're going to need mobility devices. And all of this is an opportunity also for our industry to create these kind of affordable devices that people need. And we've just come out with a report. The WHO came out with a global report on assistive technologies, showing that there is a massive, massive gap. I think something like 2 billion people in the world need some assistive device. I think most of us have spectacles. or you need a walking stick at some point of your life, of course, apart from the knees and joints that are replaced, cardiac stents and so on. But just simple things like a walking stick or a hearing aid or a spectacle or an intraocular lens is not available to a lot of people around the world. So here's an investment opportunity to manufacture assistive devices, not only for India, but for the world, which are high quality and affordable, but also inbuilt into the system these accessibility provisions. And I think the last thing I want to say here is that, we focus a lot on inputs and processes. We need to start measuring outcomes as well. And there, I think our data systems need to be strengthened. We talked about mortality. There's a huge debate about it. There is no doubt that there was a lot of excess mortality, whether or not it was due to COVID. We might have not had the COVID deaths that high-income countries had because of the age structure of our population. But there is no doubt that we had excess mortality because people did not have access to health services. We saw pregnant women dying, we saw people with cancer dying, people with heart attacks because hospitals were overwhelmed with COVID. And that is what I mean when I talk about the resilience of the health system and being able to take care of problems without overburdening our tertiary care hospitals.
Thank you. So, Minister Sudhakar, there are many points raised there, including now the fact that I think the point that Dr. Swaminathan made earlier, that while we might be living on an average till 72, but say the last 10, 12 years are very tough for most Indians. Because most Indians, if you go to the poorer populations, they don't even have basic things like spectacles, right? My number is 3.53. If I didn't have spectacles, my quality of life would be much poorer. And at some point of time, I think most people in their 60s, late 60s, 70s will need cataract surgery. But a vast majority of Indians will not have access to that. And hearing aids, and dental implants, and things like that. So she just made a follow-up point, and she said that these are also areas for entrepreneurship, because you can also manufacture on a mass scale, given the demand in the market in India, all of this at much cheaper prices, as we can do stents and valves and things like that. So,
Dr. Swati Swaminathan is absolutely right, sir. It is not how long we live, how well we live is the concept that we should understand. And especially in the last 10, 15 years of anybody's life, the quality of life should be improved. That is why our state government, with the help of the national programs, we are designing a program to ensure that anybody who is above 50 years, we are ensuring that every individual in Karnataka is subjected to the eye screening, and if there is any cataract issue, we will ensure that cataractomy is done and provide them IOL if required. Similarly, we have a very unique program for even hearing impaired and even for the children who are born with impairment, hearing impairment. So this is another unique program, and we have allocated a lot of funds for that, and we have started this program, and also the dental implants as well. That is why when I was in my initial remarks, I said participatory kind of healthcare is very important. Like in Singapore, I was observing, they have started something using this deep algorithms, where a pre-diabetic patient, they are going to constantly have a counseling with them. They'll try to find out whether there is an issue with his nourishment, nutrition, what is the kind of lifestyle that he is going ahead with. And they monitor so well, it takes time for him, it lengthens the time for him to develop from pre-diabetic to diabetic. This is what we should always observe. There's so many diseases today, we know that it is because of our lifestyle changes, because of our nutrition, because of the kind of stress management that one goes through. So when there is a participatory kind of a health program, using our lot of education tools, using machine tools and algorithms, definitely one can delay the process of a disease, whatever the disease is. So that is why this government, especially government of Karnataka under the leadership of Mr. Bommaiji, we are laying our lot of emphasis on predictive and preventive kind of a medicine. And that is the future. The second part, what Dr. Swaminathan said and what I also agree is that there is a huge opportunity for the people to invest in healthcare industry, especially the digital industry, healthcare digital mission, where there are national programs, there is a state program. You can see during COVID times how CoWIN portal has helped, how this Arogya Setu has helped us. We ourselves in Karnataka, we had more than 15 apps, right from quarantine app to, monitor the movement of the people. So technology is definitely one thing that is always holding hands of the healthcare. And I feel that innovation, one should embrace, especially the healthcare, much more we need to embrace the technology. We should allow a lot of investments in this area. And more than availability and accessibility, we should also concentrate on the affordability aspect. Because the majority of the population today, of course, they can't afford. I was reading in one of the Times of India's editions saying that due respect to the private sector and their role of healthcare in India, only the affordability, because when you compare between the public health system and the corporate health system, it costs 6 times more than what it costs to treat a patient in a public healthcare system. This is where the government and the private sector should sit and have a dialogue and see how we can make the global healthcare much more affordable in India. Like already we have started for the pharmacy, generic pharmacy. We know that this country is acting like a pharmacy to the world, because lot more than 1,550 companies have involved themselves in producing and manufacturing this generic medicine at a very affordable price. In fact, we I think have 40% of market share worldwide. And since the patents for these medicines, whatever the patented medicines, they are also getting, I think we should identify those patented drugs where their terms are getting over. So such drugs also can be considered for generic medicine. So not just the medicine should be affordable, healthcare also should be affordable. I feel the Ayushman Bharat health assurance scheme, what has been introduced in this country, it is a revolutionary step towards that. Because I can say with authority in government of Karnataka, we have catered to more than 38 lakh patients in the last 4 years, and we have spent more than 5,000 crores. That means so much. We have minimized the out-of-pocket expenditures of those communities, those families. Otherwise, the research says out of that 38 lakh people, at least 30% of people would have lost their living, they would have lost their properties, they would have lost their lands.
Well, I think most of the poor families in India, or on the margins, will go below the poverty line once the family is hit by a serious disease challenge. So having said that, Dr. Shetty, you worked on both sides, and you understand how private healthcare works and the limitations of private healthcare. At the same time, I won't say limitations of public healthcare, but I'd say the the underutilization or under leveraging of public health care? How do you get the best balance?
First of all, I show you the pattern. When I was a young kid, for any complex problem, people always went to government hospital. In fact, when I was in 7th standard, I needed tonsillectomy, and I had it done in a government hospital in Hubli. And my brother was a doctor working there, and he said that is the best hospital where you can get treated. So this was the case, but over a period of time, many things have happened. But I have just one suggestion to Honorable Minister. In case to improve the efficiency of the public hospital, he has to monitor number of surgeries done in every government hospital. Just ask one question: how many surgeries were done yesterday? How many were under general anesthesia, local anesthesia, and spinal anesthesia? If you get the right number, based on the number, you have total knowledge about how the whole hospital runs. Because to do large number of surgeries, you need to have a very busy OPD. You need to have a diagnostic lab services. You need blood bank, functioning blood bank. We need competent nurses to assist you for the operation. You need competent nurses to manage the patient after surgery. So it is very sad that the policymakers across the world in developing countries never took surgery as a important aspect of public health. In reality, every government concentrates on malaria, TB, and HIV. Malaria, TB, and HIV every year across the world treats 3 million people. Lack of access to safe surgery every year kills 17 million people. When I talk about surgery, I'm not talking about a heart operation, brain operation. I'm talking about 3 bellwether surgeries. One is a cesarean section for obstructed delivery. Second one is appendicectomy for a burst appendix. Third one is surgery for compound fracture. If these 3 procedures are done in good numbers in all our public hospitals, you have dramatically changed the public health sector completely. So we need to really concentrate on monitoring. When the head of the government hospital comes and meets Honorable Minister, he has to ask him, he will ask him how the hospitals are. He'll say, very good. What is the meaning of good? Where is the data? And you need to ask just one data. How many surgeries do you do every day? Everything will change.
Well, that's a very interesting point. It deserves an applause, which it got. Now I know that we've gone ahead of time and everybody is hungry, but we started a bit late, so we can take maybe 1 or 2 questions from the audience. If you can, the lady in the back there, please do stand up, and a mic will come to you. Will a mic come to her? I can give you a mic.
Good afternoon, everybody. I think the panel focused quite a bit on the physical health aspects. As Dr. Sudhakar was talking about, 38 lakh people have been reached out to. I think the panel must also throw a little light on the mental health aspects as well. So maybe we can address
If
that.
you would also introduce yourself, because this is being recorded.
Okay, my name is Madhuri Subbarao, and I'm also a mental health practitioner. Thank you.
So who will take it?
It's a very good question and a topic which is close to my heart as well. During COVID times, Karnataka government took the initiative of counseling almost 25 lakh people who were infected with COVID patient. So we started that because initially the person who was detected, diagnosed with COVID, he hung himself. So that was a initial thing for me to understand. People are going through mental trauma and we need to counsel that this is like any other infection, this has a treatment, and we wanted to give them the reassurance. So with that, we started that program. And after that, today we have a mental health initiative. Since we have a state-of-art institution, NIMANS in Bangalore, we have made this hub and spoke model. Like the districts, like Kolar, Chikbalapur and Tumkur as a pilot project we have taken. And we are training not just the surgeons or the specialists who are in the tertiary and secondary health facilities. We are training even MBBS doctors who are at the PHCs to know whether somebody is going through a trauma, who is going through a stress, how he should cope up with the stress. And this is how we have started, and we have roped in Robin Uthappa, the cricketer, as the brand ambassador for mental health because he had suffered himself personally for these mental health issues, especially the depression. So he is doing wonderful work, and that is how the state has taken very seriously the mental health initiative.
Thank you. Soumya,
Namaskara for all of you. My name is D.M. Iqbal. I am a retired...
Please wait for a minute because some others may also want to engage with this question. Soumya, do you want to engage with the question on mental health? We can't hear Dr. Swaminathan.
Can you hear me now?
Yes, yeah, absolutely, yes.
Okay. So I just wanted to add to the excellent points that Dr. Sudhakar just made and the very innovative tele-mental health program. I have personally seen the program at NIMHANS where they use the ECHO platform to train people at primary health centers around the country on addressing mental health issues. I just wanted to add one point on suicide prevention. Mental health is actually a very big priority for the WHO as well. And we've seen the rates of mental health problems increase. Anxiety and depression have gone up after the pandemic. And this is likely to affect many aspects of our lives. And we have to understand mental health is a construct which is, it's not a medical issue necessarily. It's also around society. And so it's a multi-sectoral approach really to creating that feeling of mental well-being. But on suicide prevention, I just wanted to mention there is a national suicide prevention policy that's been developed by a number of experts. I understand that the ministry is about to release that. It is one of the indicators in the Sustainable Development Goals. And the last report from India showed that the rates of suicide have gone up marginally. They have not gone down. And unfortunately in India, it's women in the age of 15 to 29 who are at the highest risk of suicide. And you can imagine, the reason that may be. A lot of progress can be made just by limiting access to the means. So, for example, by banning hazardous pesticides so that they cannot be bought and stored in people's homes, by responsible media reporting, by social and emotional learning for adolescents, and of course, the early intervention, as the minister was describing, at the PHC level, through call centers. A lot of suicides can be prevented. And so there are inexpensive and cost-effective means. But one of the important ones is restricting access to the means. In the US, they talk about restricting access to firearms because of the high rates of homicide. But in India, just simple intervention and it's been tried in a few districts in Tamil Nadu, where you don't allow people to store pesticides. Even if farmers are using it, it's kept in a community pesticide store, which is under lock and key, and then you go and access it when you need it for your farms. But if it's at home, then this impulse of somebody just wanting to drink it, leads to a lot of preventable suicides. Just wanted to make that additional point.
Dr. Shetty, in your practice, you find that mental health is an aspect which is not paid sufficient attention to? Because in your cardiac practice also, you deal with patients who are dealing with much bigger stresses, physical, financial, anxiety, and everything can get mixed up. So do you find that our medical profession, by and large, is adequately sensitized to the needs of mental health or not?
The mental health was not a top priority for the health practitioners until maybe a decade ago. Even though the mental health specialty existed ever since medicine started, for a doctor, it wasn't a specialty. And it wasn't a glamorous specialty for doctors to embrace mental health. But now things are changing. And this will have a big impact because as affluence sets in, the societal challenges increases, more and more number of people are undergoing stress, including the doctors themselves. The physician burnout is increasing rapidly, especially post-COVID. So these are major issues.
Well, I think we'll take the last we'll have to take the last question because it's 1:15 already. Yes.
Sir, my name is Guru Raj. I'm a CEO of an electronics company. I've been in touch with Dr. Devi Shetty for what he wants as smart devices. But my question is this, sir. With the WhatsApp invite we got for this event, it said that we need to carry masks and so I think many of us are carrying masks but not wearing them in a closed environment. My question to Dr. Soumya Swaminathan is, have we reached a point, doctor, in COVID, that we don't need to exercise any precaution?
Wait. The audio is not very clear. None of us is able to figure out. So can you hold the microphone closer to your mouth?
Yeah, so my question to Dr. Swaminathan is, have we reached a point in COVID where we don't need to exercise any more precautions like masks, sanitizers, etc.?
So that's for Dr. Soumya Swaminathan, that have we now reached that stage in the pandemic when we don't need masks and sanitizers?
Yes, I think everybody wishes because we are sick and tired of taking those precautions. But I think we're still in a very dynamic situation. And as WHO has been saying, we have not come to the end of the pandemic, even though the end is in sight. And what is happening is that we're still seeing these variants of SARS-CoV-2, particularly Omicron, circulating. It keeps on evolving and changing. And every time a virus evolves, it tries to make itself more transmissible. And so we're seeing even today, more transmissible variants. Now, the good thing is, of course, in India as well, particularly in India, I would say, is that because of the very high rates of vaccination coverage, particularly amongst the vulnerable groups, elderly and frontline workers, we have a good level of protection from both vaccination and natural infection. Even though I should add here that the booster uptake is still pretty low. I understand it's still at just around 20%. And so ideally, one should take 3 doses for effective long-term protection. But in answer to the question, I would say one has to evaluate one's risk and take reasonable precautions. This includes the wearing of masks when you are in an indoor setting where you have a few hundred people in the auditorium, where you cannot be physically distanced, where the air circulation may not be the best. In that situation, to protect yourselves and others, it's better to keep that mask. Because let's remember that COVID is not the ordinary cold. It does have damage to other organs. And so as far as possible, avoiding a COVID infection, even if you're vaccinated, we don't know what the long-term damage is going to be to the brain, to the heart, and to the respiratory system and to other organ systems. So let's take sensible precautions. And, the added advantage of wearing a mask is you're going to not only prevent COVID, but also influenza and other respiratory infections. As we are entering the season where many of these infections become more common, let's take precautions. Hand washing and mask wearing and staying at home if you're sick and not coughing and spitting in public. These are things that many countries follow, pre-pandemic and will continue to follow. If you walk into Hong Kong or Japan, people wear masks when they feel that they have a cold because they want to protect others. So I think these are just basic good hygiene principles, and I hope we can continue to adopt them and use them sensibly.
Thank you. I'll request each one of the other two distinguished panelists to just answer this in half a minute each. Have we reached that stage yet, and what is your advice? And I think we'd have to wind up, unfortunately. So have we reached the stage where people can now forget about masks and sanitization, so back to normal?
I personally started seeing patients without mask, but good number of my patients do wear mask. I feel that as a doctor, I am 100% exposed to COVID many times, and I am resistant, but God only knows, but I prefer not to wear mask.
I totally endorse.
See the sentiment of not wearing a mask gets an applause, which is a bit worrying, I must say. We have to have much greater humility dealing with these viruses, sir.
But I would like to endorse Dr. Swaminathan's view. We should take adequate precaution depending on one's health, and we all know individually how strong we are and what is our physical status. It is better always to have prevention taken.
Well, thank you very much, and I'm afraid we've overshot our time greatly, so we'll have to bring this session to an end. Thank you very much. You've been marvelous, Dr. Swaminathan. We apologize again to keep you waiting. We know that you have many things to do. And you know what's happened as a result of all this confusion, the delay in our start, that is you are being deprived of a half-hour closing speech that I had worked so hard at preparing. So it's your loss, what can I do? So go ahead and have your lunch, and thank you very much for being here. And thank you, Soumya. Bye-bye.
Thank you.
Would request guests to please stay back. Shekhar mentioned overshot on time, but it was all time put to good use. Yes, this side. Happy to see you on stage. And please, may I request Mr. Murugesh Nirani, the Sachivaru, Large and Medium Industries Minister, to please step up on stage to offer tokens of gratitude to all the guests who have joined us. Dr. Soumya, of course, can only accept it virtually, but it was wonderful to hear all those inputs and insights, to see healthcare not as an expenditure, but as investment. And that cautionary note, particularly on COVID not yet being over. I think that should give us some sense of a reality check as well. But to hear from Dr. Devi Shetty, from Dr. Sudhakar and Mr. Shekhar Gupta is good. May I invite, yes, the mementos are being offered. And I would like to remind the audience about another session which you should not miss, which is on Resilient Karnataka Success Stories. A little change in the venue. It's now in Auditorium 2. Please make note, Yeredne Hall alide. Resilient Karnataka Success Stories, 2 p.m. And please do not miss the grand closing ceremony at this hall, the Global Investors Meet 2022, when it will come to a wrap. Meanwhile, enjoy more food at the Uta after Food for Thought. And thank you for being such a wonderful audience. It's time for me, Vasanthi Hari Prakash, to sign off from this part. Namaskara.